Thank you for having me here. Let me just share a bit and then what I found from other researchers. So this is the life expectancy from each country, like Asian countries and United States, and then world average. So you can see that the world average is 72.5, and Japan is really the number one, almost the number one country in terms of life expectancy at birth. And you can see that South Korea have just caught up very rapidly with that. And the United States is a little bit caught up and now is just flattened out. And China is really catching up. So this is the demographic pyramid by each country. You can see that this is the pyramid of Japan. So you can see that this is called Dankai generation. This is the post-World World War boomer generation in Japan. So they're just reaching at this point. This is the second generation from the boomers. And then now you can see that the this birth rate is really getting decreased here in Japan. But South Korea is having more serious problem with that in terms of that. So now you can see that this trend is this bulk generation is following it to this Dankai generation. And then we didn't even see some second generation fact here. It's not very prominent like this. And this birth rate is really low these days, so it's really not stable population pyramid. And China, you can see that also there's some time lag of this structure that there's also catching up. This boomer generation is just going up. Compared to these three Asian countries, United States have relatively stable demographic pyramid. So you can see that they have just reaching up, but there are really some stable birth rate compared to other Asian countries. So now it leads to outcome status because we are interested in relationship between dementia and air pollution. Let's look at the outcome prevalence first. So it's expected that by year of 2015, the Asia will be the most prevalent dementia region, and America will be the next, and the third will be Europe, and the last will be Africa. So in world, the total number of dementia is 152 million. And you can see that more than half of this world dementia will come from Asia. Now we'll get the exposure status. We expect that Asian countries have more dementia. And what about then exposure status? It's really obvious that compared to North America and Europe, Asian continents has higher air pollution levels. So India, China, and South Korea, and Japan. Japan is relatively cleaner because this location. And I just want to compare the annual PM 2.5 concentration by country. So this is the graph about that. So in the U.S., I tried to look up the most recent and relevant data, and then according to the U.S. EPA, the last year's annual PM 2.5 concentration was 7.8, which was really good. And Japan's PM 2.5 annual concentration was 8.5. And compared to that, South Korea and China has more higher concentration rate. So this exposure range is much higher compared to the US. So now we can see that we have now different exposure range here. Sorry. So you can see that this is the publication from Dr. Shi, and she published this paper about air pollution and its relation to Parkinson's disease and Alzheimer's disease. But up until this level, around 16, she found some linear relationship between increased air pollution exposure and the risk of dementia and Parkinson's disease and Alzheimer's. But after this exposure range, not surprisingly, these relationships started to flatten out, and it started to have very wider confidence interval ranges. So it's really kind of not surprising, because the average distribution of exposure range is very low, and compared to any Asian countries. So I looked up a little bit about Chinese studies, and then here their exposure range definitely different. So they start from 25 microgram per cubic meter up to 50, and so this range is after, it's kind of like represent the upper extreme of exposure of United States studies. So you can see that after this exposure range, you can still see that the increasing hazard ratio. So if you combine these two data from 0 to 50 microgram per cubic meter, you want to observe very linear relationship, consistent linear relationship with this dementia disease and exposure data. And this is why international collaboration for data storage is needed. So recent review just said that our estimate also indicate some uncertainty in this relationship, and future epidemiology studies at high exposure levels are especially needed. So I think there are a lot of the need for the relationship between air pollution and dementia in Asian countries. I'm not going to talk very much about that. Other than that absolute number of exposure status, we have different chemical composition. So maybe this can be another future research goal. Now I want to talk about some vulnerability of Asian population. So now I compared these relationship between countries, but this study is conducted in the United States. So these these Asians are residing in the US. That means they share these only exposure status. So you can see that this is the age of hazard instance of dementia, and this is the reference group of white. And more than white group, Asian population shows higher risk of dementia. So with, even within the same exposure range, sharing the same environment, Asians have higher risk of dementia than the US white population. So now, because of that, global burden of dementia attributable to PM2.5 will be picked up in these China and Japan groups, Asian countries. This global burden of disease is from 2000 data, and this is a 2015 data. And here we saw data from Italy, but now it's replaced by Asian countries. So it's really expecting that we will have much vulnerability towards air pollution in terms of dementia risk. So now, these days, I found that there are a lot of research about air pollution and dementia. So I searched PubMed using these very simple, keywords, and I can see these increasing trend. So up until 2010, there was not very much study, but after 2010, we see that this very high number of research about air pollution and dementia. So now, today is May, and around even May of 2024, we already see the new studies about this relationship is just 45 studies. So then among these data, I selected only meta-analysis and review and system reviews, and still I found a good number of reviews and meta-analysis studies. So that's why we did this umbrella review about this relationship. So umbrella review is a tertiary research. So umbrella review is a systematic review of system reviews. So it's an overview of system reviews. So this is the hierarchy of the system. So you conduct individual study, and this is a primary research. And then the secondary research is called systemic reviews or meta-analysis. Then umbrella review just reviews these secondary status data and then review study. So we call it, this is a tertiary research. So to review reviews, there were two independent reviewers, and then they evaluated these review studies, including meta-analysis based on the JBI critical appraisal checklist. And after that, we put together some results from meta-analysis and the system reviews in one place. And this is the result. I'm sorry that there's some inconsistency about these units. And this is the verdict from each review. So I said we have 5 reviews, and this is a narrative reviews, and each blue dot means favors the relationship, and then this orange dot means it's less towards the null hypothesis. So in general, they made a verdict, each review verdict that air pollution have some suggestive relationship between these neurodegenerative disorders. So most findings are among air pollutants, PM2.5 was prominent, and this tells policy priorities of air quality should be given to the control of PM2.5 to prevent Alzheimer's disease and other dementia. Let's get into more about then the research, how research are going on in Asian countries. So this is epidemiological studies about relationship between air pollution and dementia by country. So I mapped out, so it may not necessarily very accurate data because I just did just not from our publication. This is just general trend, and then you can see that North America and every continent have the most highest number of publications here. And Europe has some publication, and there are some Asian studies from Asia, Taiwan, China, Taiwan, and one study from South Korea in terms of clinical dementia. So there's not much studies here, and then you can see that the absolute number of studies are lacking for the prevalence of outcome and the high exposure status in these areas. So I summarized the methodology about Asian studies from the Asia, because we now found that the absolute numbers are lacking, and what about then outcome or research methodology? So as far as I know, in terms of clinical dementia and Alzheimer's disease, they all use administrative health database. It's based on the background of this healthcare background of those Asian countries, because Taiwan, South Korea, Japan shares this universal healthcare system. So they contain every citizen's health record. So maybe it's easier for them to use this administrative health database. And in terms of exposure assessment, they still use these ground monitoring stations. Some study use kriging without satellite data, it's univariate, and no other land use variables. And one study used land use regression without satellite coverage. And one study used PM2.5 map using satellite erodic data, but they didn't do calibration using land use variables. And one study did some region modeling. And most of studies still use ground PM2.5 level data from existing ground monitoring stations. But using of the administrative data set for epidemiological research is really good, but at the same time, I should admit from my experience that I did this kind of analysis before, is that this administrative database is not for originally research. It's the main purpose is the administration, definitely. So there's some gap between actual onset of dementia and its diagnosis. So during this time period, access to healthcare really plays a critical role to find this dementia. So sometimes it's really hard to say instant dementia. So it's kind of like recording of dementia. So sometimes these may lead to, but if access to healthcare happens equally to each people, that will be relatively fine. But the thing is, this access to healthcare can be different by people. So this person, for example, will have higher education level, and then if they develop dementia, then they're gonna have shorter period of time to get diagnosis. But this person, if they person have lower education level, maybe they're gonna have some delayed period between dementia onset and diagnosis. Or even more, unfortunately, if in this person, they get some subclinical dementia but died before, and then they're gonna miss this diagnosis chance. So this might affect, because for dementia analysis, time to event modeling is used. So this time delay might have some impact on the modeling of relationship, hazard ratio calculation, fitting Cox proportion hazard model. So I really searched about it, and then there's some article that if proportional that assumption holds, then fine, but yeah, I'm not sure about that. So I found this interesting review that how the result can be different by outcome ascertainment method. So this is a review recently published by Walker, and she did some subgroup analysis for her review. And this is passive outcome ascertainment. This is active outcome ascertainment. So active ascertainment means you do some core studies. And passive ascertainment study, you just make use of these existing administrative data set. Means like this. And then, interestingly, she found that the studies that use active outcome ascertainments reported higher hazard ratio. So compared to the studies that use passive outcome ascertainment. So at the same time, that administrative records have good potential. So I would clarify some pros and cons or from each study design. Some core study will have less outcome classification because you just follow them up and you're gonna detect it early on enough. And it will have more covariates. It means these social exposure factors like income, education, or other exposure covariates. On the other hand, those insurance claims, administrative records, they will have tremendous sample size. This is the number one good trait of this type of data source. And because it will have less selection bias because it will cover entire sections. And sometimes it's not very plausible, but for now, but maybe it will enable studies on early onset dementia. So it has some potential about this topic as well. These advantages of cohort study is really not feasible. Sometimes it's really hard to follow up on these cohort participants. I really get that. And then, but administrative records, they have some outcome risk classification issues that I said earlier in this slide. And because this is administrative records, they don't lack many covariates, so they're going to have less covariates. So maybe with the background of that universal healthcare system, maybe it would be good to have some data linkage for future research in Asia. So from the core studies, you may have some instant dementia, and you're going to have more covariates. And sometimes you can use this data to validate data from administrative data set. And for administrative records, you can get these good advantages of more sample size, or sometimes if they miss, if some lost follow-up happens, they can check their diagnosis record later on, and then check these outcome. They can check the outcome status. This type of linkage is happening in South Korea. As far as I know, some consent will be made at the moment for cohort participants, and then they allow researchers to check their medical records later on. So now I talked about some outcome ascertainment issue about studies from Asian countries. What about the exposure assessment? So this is the cell light data, continuous cell light data based a PM2.5 level, and these dot means monitoring stations. There are two options I want to compare these two methodologies for exposure assessment in the relationship of PM2.5 with dementia. So I ran the model separately using these exposure model or these exposure assessment method from just ground monitoring stations. And interestingly, this is the result of this comparison by exposure assessment and urbanization. So this is hazard ratio, and this is the area, and the rural area, and micropolitan area, and this is the metropolitan area. That means most urbanized area, less urbanized area, and the rural area. And you can see that these thick line means hazard ratio based on cell light based AOD use GIE based methodology, and this result is ground monitoring data results that use ground monitoring data set. So it's really consistently show that cell light based methodology shows better performance, and ground monitoring data shows bias towards null bias. And interestingly, this gap was huge in this rural area. So these bias towards null bias is really salient in these rural areas. So Mount Sinai has in good hands in terms of this advanced exposure assessment. After it Hokkaido, so maybe can you believe in terms of this exposure assessment aspect. I was also a little curious about air pollution's impact to dementia, because existing study just established that air pollution causes cardiovascular disease. And I was a little curious if this established, then this pollution will subsequently cause dementia. So I just a little bit made some subset of dementia type, all dementia, Alzheimer's, and vascular disease. And I found that some vascular dementia showed a bit higher relationship, but still this data is based on administrative data set, so I didn't see much significant different estimates. So, and I checked other studies as well. It seems like vascular dementia showed a bit higher hazard ratio than Alzheimer's disease. So maybe I'm just curious if maybe this result should be checked in the future studies. Let me just wrap up here. There's some research gaps in Asia in terms of the relationship between air pollution and dementia. So higher prevalence of dementia due to rapid aging is expected. And Asia have more exposure to Asian populations, have more exposure to air pollution. And as I showed in the studies from the United States, Asian population have a higher susceptibility compared to other races. But there's something that we need to discuss, because maybe that Asian population can live with different traits compared to Asians who are living in Asia. But anyway, but despite that, there's lack of research in Asia in terms of absolute number. And also, there's something gaps in outcome ascertainment and exposure assessment. This is a completing remarks. So air quality is a critical component of exposure that affects human health, starting from the uterus throughout the terminal stage of life. For such significance, epidemiological studies in Asia still lack. Especially for dementia, more studies are needed from Asian countries with rapid aging and higher air pollution levels. But yet, Asia have a lot of research potential because they have a good research infrastructure based on their universal healthcare system, and they have taken initiatives for ongoing core studies like JET study, even though we're dealing with dementia yet. So for that, international collaborations on exposome for planetary health and the coming generations are needed. Thank you so much.
Thank you very much.